Hello, everyone. Can you guys hear me? If you can, please write down in the chat box that you guys can hear me and you can see the screen. And let's get started. Great. Awesome. Let's go. Let's start. Thank you. Thank you, Dr. Roger. Thanks. All right. Let's talk about male reproductive anatomy. Okay. With this, first of all, let's take a look here. Pathway, high yield, the pathway for sperm during ejaculation. The mnemonic is 7-up. First of all, you have seminiferous tubules. So while we're going to read this, we also have to visualize them. That's easy way to understand and memorize. So seminiferous tubules right here. So let's just write one here. Okay, let's do one. So that's the first thing, seminiferous tubules. If you just take a look, let's just zoom in here. Before the seminiferous tubules, we have something known as tunica albuginea, right? And on top of tunica albuginea, this whole thing, which is just the white portion here, let's actually write this down as well. So we have tunica albuginea, and on top of tunica albuginea, there's going to be something called as tunica vaginalis. And why am I mentioning all this? Because you won't see them. So it's better to know right now than you figure out later on that, hey, there was something else. So this is tunica vaginalis. Okay. And just remember, what did I say? I said it's on top. It is on top of tunica albuginea. So let's talk about one more thing here. If we have, first of all, let's talk about tunica albuginea a little bit. So tunica albuginea is just a fibrous tissue that immediately, if you can see, it's immediately overlying the testes itself. Okay. And it is beneath tunica vaginalis, right? So, so if we have an excess collagen, because this is all about, this is a fibrous tissue, right? This is a fibrous tissue. If we have excess collagen here, what's going to happen is that excess collagen will give pain and curvature of the penis to see that is seen in the Peyronie disease. Okay, so excess collagen within it, again, what am I saying? Excess collagen within tunica albuginea will give you something known as Peyronie disease or Peyronie disease, which is essentially just the pain and curvature of the penis is abnormal, and it gives the pain, and that's called the Peyronie disease. The second thing we're going to talk about is tunica vaginalis, which is on top of albuginea, right? Right here. So this tunica vaginalis, if there is a problem within tunica vaginalis, or there is something, a pathology, then that's going to be the hydrocele. Hydrocele, and we will talk about that later on. With that, let's move on to the topic 7-ups. 7-up is the mnemonic. What do we have? We have seminiferous tubules. That's the first thing right here, seminiferous tubules. Then we have epididymis. So if you look, all these seminiferous tubules, they are going into epididymis. This whole thing is epididymis, right? We have head of epididymis, afferent ductules. Another thing that you will see that is called the that is going to be, let's talk about epididymis a little bit here first. Epididymis is all about, it's a coil tube. As you can see, it's a coil tube, right? It's a coiled, let me just write here, coil tube, which lies posterior to the testes. Where does it lie? This is testes, so it lies posterior to the testes, right? That's another point. It is responsible for. Well, why do we have all this coiled tube? I mean, you must say this, right? Why do we have all this? Why can't we just have straight up a line or a tube? Why is it all coiled? Because it's the storage. It is responsible for storage, maturation, and transport of the sperms. So it's a storage of all those sperms within this epididymis. So storage, maturation, and transport. Okay. So that's the epididymis. That's going to be our second. The third thing we have is, so that's first. This is second. Third is vas deferens, right? So this is the vas deferens. So if you look here, from this epididymis, all we are getting out, only one tube, that is known as vas deferens. Important, high yield vas deferens. Why is that important? We do vasectomy. If you can recall a little bit, we can do vasectomy, and vasectomy is just we are transecting vas deferens, and we will talk about that in a bit. But here, the third point is vas deferens. Then the fourth is ejaculatory ducts. So we're gonna go back to the normal image here now. Okay, so we were here at the vas deferens. This is vas deferens. This is third. Now, if you look here, from testes, from epididymis, everything was going into this vas deferens. And from vas deferens, it is going to travel into ejaculatory ducts. This is the fourth. And let me zoom out here. Here's the fourth, ejaculatory ducts. Now, then you have fifth, which is from ejaculatory ducts. It's just going to go into urethra. Let's just look at that. Here's the ejaculatory duct. It is going into the urethra, right? And from urethra, it is going to go straight into outside. Okay. So this is the normal pathway for ejaculation. So the mnemonic here is pretty good, 7 ups. S is for seminiferous tubules, E epididymis, V for vas deferens, E is again for ejaculatory ducts. N is nothing, okay. It's just there to make up a mnemonic. Then urethra and penis. If you can memorize it, great. If not, just remember a little bit of it and you'll be good to go. But now let's talk about something known as vasectomy, okay? That's important. So in vasectomy, what are we doing? We are going to have, it's a male contraception, okay? It's a permanent sort of contraception unless there's a valve there. But it's, now the important point is, even after vasectomy, let's talk about a little details here. So first of all, what is vasectomy? Let's talk about vasectomy. Vasectomy. Now in vasectomy, there is a transection of this vas deferens, okay? But after the transection, now the problem arises that even if you do this transection, there are still viable sperms which remain in the portion of this vas deferens, the remaining portion of the vas deferens, which are good for about 3 months. So you think about it, you do vasectomy and say, hey, we're doing contraception, but it's not contraception because those sperms which are distal to the part where you did the vasectomy, they are still there and they can run about for 3 months, okay, or 20 ejaculations, okay. So pregnancy, now important point becomes, so pregnancy is still viable, it's still possible. So what you got to tell the patients, use some other sort of contraception. So like, for example, birth pills, anything, till semen analysis confirms azoospermia. You got to do semen analysis, and that should tell us azoospermia. And that's normally seen after 3 months. So 3 months, there is no contraception. So after vasectomy, Sexual desire, and now a couple of questions the patient might ask. So once they have the vasectomy, so sexual desire and satisfactions remain normal. Okay, no problem in maintaining erections. Vasectomy has little effect on volume of ejaculation. So some people have this thing, okay, we have vasectomy, there is going to be nothing, but that's not the case. The volume of ejaculate is going to be normal, okay? As sperms, they only make about 2 to 5% of the semen by volume. And semen is mainly composed of fluid secreted by seminal vesicles and prostate. Okay. What about testosterone if after vasectomy? So testosterone production would be same as a pre-vasectomy. So say normal testosterone levels. Viables, the only thing that's going to be different is going to be viable sperms. Viable sperms for 3 months or minimum 20 ejaculates are going to be present post the level of vasectomy, and after that the patient will have azoospermia, and that's the only thing they don't have is the sperms, nothing else. Everything else is normal. Now this is when we do vasectomy from outside. What about some patients have congenital absence of vas deferens, right? Congenital absence of vas. So same thing, everything same in those patients who have congenital absence of a vas deferens. Everything same. Only one thing is going to be that they will have a low sperm count or low sperm volume. Acid pH, and they're going to have an acidic pH of the ejaculate. Okay, 2 things here. Other than that, everything is same as vasectomy. Okay, so let's just recall the whole thing and move on to the next. Okay, so we talked about how the pathway of ejaculate is from seminiferous tubules all the way to the epididymis, and then vas deferens. From vas deferens all the way to ejaculate reduct, from there urethra, and then straight out in the penis, right? And then we have we talked about tubica albuginea, and on top of it we said there's a tunica vaginalis, tunica vaginalis, and that is associated with hydrocele, and tunica albuginea is associated with Peyronie disease. And then the last thing we can think of is, what is epididymis? It stores there is a storage, maturation, and transportation of sperms within epididymis. That's why we have the coiled tubes. And that's pretty much it. Let's move on to next. All right, now let's talk about genitourinary trauma. Okay, it is the most commonly due to blunt trauma, for example, MVC or MVA, motor vehicle collisions. Okay, with that, let's take a look at the first one. We can have a renal injury, bladder injury, or urethral injury. So renal injury is going to present with bruises, flank pain, high yield, because if you recall, where is the renal located? It's in the flanks, of flank pain, with hematuria, okay, caused by direct blows or lower rib fracture. Again, lower ribs, so this is sort of your thorax. You have the lower ribs, and you have kidney. If you have a lower rib fracture, you can penetrate into the kidney, causing trauma, right? Or direct blow to the flank can also give you trauma. But important thing is you can have a bruise from outside, a flank pain, and hematuria, okay? And that's with the renal injury. Now, looking at the bladder injury, it's again going to present with hematuria. Again, if you look, it's the common thing, but now what you're not going to see is the flank pain. Flank pain, you will not see with bladder injury. You have hematuria common. In the bladder, because the location is not in the flanks, the location is in the suprapubic pain. So right, like anteriorly anterior abdomen, lower anterior abdomen. That's where you're gonna have the pain. It's called the suprapubic again pain, right? And difficulty whiting. So superior bladder wall, which is a dome injury, can lead to it's a direct trauma to the full bladder. For example, seat belts. So seat belt can cause trauma to the superior part of the bladder, and that can give a dome injury or direct trauma to the full bladder, leading to abrupt increase in intravesical pressure, causes dome to rupture, which is the weakest part, leading to intraperitoneal urine accumulation, high yield. And why is it high yield? We'll talk about that. That peritoneal absorption of the urine is going to cause increase in bun and creatinine. Okay, now anterior part of the bladder or the neck injury can be caused by pelvic fracture, which can perforate by the bony spicules, causing extra peritoneal urine accumulation, which is retropubic space. Okay. So here is the retropubic space. Let's take a look. We have a retropubic space, and you can see how if we have an anterior, so this is anteriorly, right? If we have an anterior trauma to the bladder, anterior bladder wall trauma or neck trauma, the urine is going to come out, but it's going to be in the retropubic space, which is extraperitoneal. It is extraperitoneal. While if you have the dom, or let's say the superior bladder, which is known as the dom, right? This is the dom, right? Dom of the bladder. So if you have a superior part of the bladder injured, you're gonna have urine going into intraperitoneal cavity, right? Intraperitoneal cavity. And that urine that goes into the intraperitoneal cavity will give you increase in bun and creatinine, because there is going to be absorption of that urine. Okay, and what does urine have? Bun and creatinine. Everything is going to get reabsorbed, going to cause increase in bun and creatinine. There's nothing going out. It's just getting reabsorbed, right? So that's the way you think about it. Okay, now let's talk about this urethral injury. Urethral injury occurs almost exclusively in males because they have the longer urethra. Okay, it's going to present with blood at urethral meatus, high yield, blood at urethral meatus, hematuria, difficulty whiting. I mean, if you look at it, everything looks the same, right? And I'll make sure that you get this at the end of this page. I'll review it, but it's similar things here. But what is going to be different is going to be the history of patient. How's that patient presented? Okay, where's the pain? That's another thing, but we'll talk about it in a bit. So we have difficulty whiting, and then urethral catheterization is relatively contraindicated because you don't know where's the injuries, right? You don't want to go for urethral catheterization and destroy more, right? Because if you think about it, let's say you have injury here and you're putting the catheter in, you can injure this area more, right? So what do you do then? Well, the way they should have written here, but you have to then first perform retrograde urethrogram, which basically goes in retrograde and tells us where's the injury is. So maybe we see, hey, there is no injury here. Why do we have urine in here then? Then we can put the Foley's and see where it is through camera and everything else. But what do we do when we have urethral injury? We cannot put a urethral catheterization, which is also known as Foley's catheter, right? We can't put this. So why? Because we don't know where the injury is. So how do we check where the injury is? Well, we do retrograde uretrogram to assess the urethral integrity, right? And then if you say, hey, everything is good, then we put Foley's in. But this is the normal way of doing things. But here, the anterior urethral injury, there is two types. So you got the anterior and the posterior urethral injury. So the anterior urethral injury, we have perineal saddle injury, for example. How are you going to get a perineal straddle injury? That's going to be if, for example, if the perineum is struck forcefully. Example, how it's, for example, very classically, you will see that the patient will be falling on a ladder with legs open. So falling on ladder with legs open. That's perineal injury, right? That's one thing. You can also have falling on the crossbar of the bicycle or top of the fence. Anything which gives the injury to the perineum. And these are three examples that I just mentioned. That is going to disrupt the bulbar urethra, which is also known as a spongy urethra, which is going to cause scrotal hematoma. If buck fascia is torn, the urine would escape into the perineal space. So let's take a look at this image here. So we have anterior urethral injury. We can see that, but first of all, we want to talk about something. There are a couple parts of the urethra. So we have penile urethra. So let's just mention it, a penile urethra. We have bulbar segment of the urethra. So penile segment, I should say. Penile segment of urethra. We have bulbar, which is this part. Okay, this whole thing is the bulbar segment. Okay, and then we have so these two things, which are the penile segment and the bulbar, they are known as anterior urethra. And if we have an anterior, we should have posterior as well, right? So whatever is back there is going to be posterior, but there are names to that. So we have a prostatic urethra. Let me do this. This is a prostate. So whatever urethra which is within the prostate is called as prostatic urethra. Okay. And then we have another one which just comes off once it comes out of the prostate. It is known as membranous urethra. Okay, now this membranous urethra and the prostate urethra, they are now known as, so let's just do this. These two guys are called posterior urethra. Okay, that's important, and it is important to know all these things. If you don't learn it right now, you're going to learn it later on with a little bit of twist. So just learn it right now. You'll be good to go. So what do we have? Again, five parts of urethra. We got the penile urethra. We got the bulbar. These are all anterior urethra. Okay, if we have, and now when we talk about anterior urethral injury, you're going to think of two things, and I'll talk about that. But in the posterior part of the urethra, we have prostate urethra and we have the membranous urethra. That membranous and prostate, they're all posterior urethra. So now with that, let's mention the problems here. So when we have the anterior urethral injury, that could be due to the perineal straddle injury, right? And that would disrupt the bulbar right here, this guy. That would disrupt this bulbar spongy urethra, which is going to give, so if you have a problem here, it's going to leak urethra into the scrotum, right? Causing scrotal hematoma, if you can see here, right? Because of all the injury. And if the buck fascia is torn, that urine can escape into the perineal space. Now, which they did not mention here, they should have mentioned here. Now, if you have a problem, for example, this is only the bulbar segment, but what about who's going to damage the penile segment of the urethra, of the anterior part of the urethra? So that's going to be most commonly injured Intragenically, for example, what is that? That's going to be the instrumentation. For example, you're putting the Foley's catheter in. The most common urethra, or part of urethra, I should say, that you're going to damage is going to be the penile segment. So most common injured in penetrating trauma. Penetrating trauma. High yield. Most commonly seen in the penetrating trauma or instrumentation. Instrumentation. And that's the penile segment of the urethra. Okay. While the bulbar is associated more to the perineal stratal injury. For example, I mentioned if you have a falling on the ladder with legs open, or falling on a crossbar on a bicycle, anything that you think of, and you have a perineal injury, then you think of bulbar segment damaged. Okay, so that's all the anterior part. Let's talk about the posterior. Now, posterior urethral injury is going to be pelvic fracture. Now, pelvic fracture, if you look here, because it is in the pelvis, this posterior part of urethra, where is it? It's in the pelvis. So pelvic fracture is for sure is going to give you posterior urethral injury, right? It's going to disrupt at, now important thing is going to be the location, right? Where is going to be the problem? Well, it's going to be in the bulbo-membranous junction, which is the weakest part. Here, take a look at this. So right after, because if you think about it, the prostate, you got to destroy the prostate in order to destroy the prostatic part of urethra, right? So what is going to be the most common posteriorly, or in the posterior urethra? Well, the most common is going to be whichever is exposed. What is exposed is your bulbo-membranous urethra. So if you have a pelvic injury, guess what? Which part are you going to destroy? Bulbo-membranous urethra, or you can call it junction, because there is a junction to the from the bulbo to the membranous urethra. Okay, so torn bulbo-membranous junction, which is the weakest part, which causes urine leakage into the retropubic space at the high riding prostate. That's very high yield. So in the posterior part of the urethral injury, the most common thing that you will see is going to be urine leakage into retropubic space. Where is that located? Right here. It is the retropubic space. And on top of that, you will have a high riding prostate. And high riding prostate. Sometimes it is called that boggy prostate. So let me just mention this thing. Boggy prostate. Okay, and why is it high riding? Because there's a hematoma that's going to form, that is forming beneath it. So it's pushing it up, causing high riding prostate or boggy prostate. Okay. Okay, so now let's just review the whole thing and move on to next. So we have two things in which we are going to have retropubic space, or urine leakage into the retropubic space, and both are associated with, if you think about it here, you have accumulation in the retropubic space, which is the anterior bladder wall or neck injury, which is this part, right? Or secondly, you can have a posterior urethral injury, which is again in a close proximity right here, right? So this, both are going to give you a retropubic space urine, but this one, urethral injury, also going to give you high riding prostate. Okay, that's one thing. Now compare that with the superior bladder wall injury. It is going to have intraperitoneal urine accumulation. Okay, which you do not see anywhere else. So this intraperitoneal urine accumulation is not seen in anywhere else. In anywhere else. For example, this is only with a superior bladder wall injury. Okay. Lastly, with the anterior wall injury of the, anterior urethral injury, you will see the urine might escape into the perineal space, or the important thing that you will see is going to be this scrotal hematoma, or swelling of the scrotum. due to the fact that if you have a damage here, all that urine, everything is going to go down into the scrotal sac. Okay. With that, let's move on to the next part. Now we have anatomic innervation of the male sexual response. Here, what we have is so we have erection, emission, expulsion. Erection is through parasympathetic nervous system, pelvic splanchnic nerves, S2, S4. There's a very nice mnemonic here: S2, 3, and 4 keep the penis off floor. So 2 to 4 are keeping the penis off floor, which is the erection. Again, important to memorize this. Simple yet important. Okay, and how is that happening? Well, there's a nitric oxide which causes increase in cyclic GMP, causes smooth muscle relaxation, causes vasodilation. That vasodilation, now the whole thing is about vasodilation, right? Which causes proerectile. Norepinephrine is going to cause increase in calcium influx, causes smooth muscle contraction, which causes vasoconstriction and anti-erectile. So sympathetic activity is anti-erectile, versus nitric oxide is a pro-erectile. Okay. Now emission is through sympathetic nervous system, through hypogastric nerve, which is coming from T11 to L2. Expulsion is through visceral and somatic nerves, which is the pudendal nerve. So the mnemonic here is point, which is through parasympathetic. Squeeze is through sympathetic, which is emission. And shoot is expulsion, is through somatic nerve. Again, what you want to know is all these nerves. So point is for parasympathetic. With parasympathetic, you're going to think of your S2 and S4, right? And then you have squeeze is through sympathetic. Sympathetic, you will think of hypogastric nerve, hypogastric nerve. And lastly, you have shoot. Shoot is going to be for the somatic nerve, which is pudendal nerve. And then you have the PDE5 inhibitor, which is sildenafil. This is going to cause decrease in cyclic GMP breakdown, right? If you recall, you have cyclic GMP, which is doing all this vasodilation action, but it is broken down by PDE5s, right? Now, you want to keep this cyclic GMP keep on working, causing vasodilation, and be more active, not get destroyed, right? So let's just put it here. So cyclic GMP, what does it cause? It causes vasodilation. It is broken down by PDE5 into its inactive, let's say inactive cyclic GMPs. Actually inactive metabolites, but I'm just going to put cyclic GMP, but inactive form. Now, who's doing this? Inactivation, that's the PDE5. If you knock this out, if you remove it, if you inhibit it, right, now what you're going to have is it will lead to increased cyclic GMPs, which are going to cause increase, mean more and more vasodilation, or for a longer period of time without any inhibition. And that is done through sildenafil. So sildenafil is going, let me just change color. Sildenafil is going to inhibit the PDE5s. When you inhibit PDE5, causing increased cyclic GMPs, causing increased vasodilation for a longer period of time. Okay. And that's exactly what's written here. PDE5 inhibitor is the sildenafil, which causes decreased breakdown of cyclic GMP. And that is pretty much it. Okay, what we're gonna do is I will have a 7 minutes break. Okay, and then that 7 minutes, don't take them light. Okay, just maybe you want to go over this page. Okay, and we did 2 pages, so out of 2 pages, so go over these pages, and then after 7 minutes, we're gonna continue. Uh, okay, Dr. Kalim, the problem is that I thought I fixed it. I know there was a problem in the voice. I know that part, but I did fix it. Okay. Um, can you guys hear me right these days? I don't know. I mean, I thought that it's pretty good, but do let me know. Give me a feedback on it. I'm happy to fix it. Okay. Starting timer now. Okay, welcome back. Let's talk about seminiferous tubules. Seminiferous tubules. So whatever I'm going to talk about in this page, remember it's going to be male, okay? Male, only male. So let's talk about spermatogonia. Well, spermatogonia function is going to maintain germ cell pool and produce primary spermatocytes, right? Location. Well, it is located in it lines the seminiferous tubules, germ cells. These are the germ cells. Let's take a look at picture A. Here's the picture A. We have seminiferous tubules. So this whole thing is the seminiferous tubule. Okay. And here, what do we see? We have from this all the way inwards, we have the formation of sperms, right? So the way we're going to think of these things are going to be, we have spermatogonia. Let's just write them down. These are all spermatocytes differentiation. So from here we have spermatogonia. Let's just write them. Spermatogonia. Okay. From there, these are going to differentiate into the primary spermatocytes. And from primary spermatocytes, they are going to form the spermatids. And that is just going to cause formation of spermatozoa. So when we have these spermatocytes, if you look at these ones, which are a little broader, so these are the secondary spermatocytes. But this is the way how this spermatocyte differentiation is. With that, let's take a look at the top. We said spermatogonia is going to be the germ cell pool, which is going to produce that primary spermatocytes. And these are all germ cells. Now, more importantly, that is going to be the Sertoli cell and Leydig cell, high yield. Let's talk about those now. So Sertoli cells, they secrete inhibin B, which inhibits FSH. They secrete androgen binding proteins, high yield, which maintain local levels of testosterone. So androgen binding proteins. They also produce MIF, Mullerian inhibitory factor. That's also high yield. They have tight junctions between the adjacent Sertoli cells, form the blood-testis barrier, which isolates the gametes from autoimmune attack. So this blood-testis barrier, the blood-brain barrier, where there is something blood-testis barrier, which is going to isolate the gametes from autoimmune attack, so the body's own cells don't destroy the gametes. Okay, the Sertoli cell function is to support and nourish the developing spermatozoa. They regulate spermatogenesis, high yield. They are temperature sensitive, decrease sperm production, and decrease inhibin B with increase in temperature, high yield. So when you have an increase in temperature, there is going to be decrease in sperm production. Okay, and that is the actual reason. That is why testes are not within the intra-abdominal cavity. They're outside. As you can recall, they travel from intra-abdominal cavity all the way into the scrotum due to the fact of this temperature sensitivity. Okay, because if you have increased temperature, there's going to be decrease in sperm production. And when you're outside so there is not, temperature is not that high as compared with intra-abdominal temperature and peritoneal temperature, right? So that is why these Sertoli cells are important for the temperature, high yield point. Now, let's look at the other notes here. So they line the seminiferous tubules. So Sertoli cells, so let's take a look here. So we have seminiferous tubules. Here are the Sertoli cells, right? They line the seminiferous tubules. Okay, these are this is the lumen of seminiferous tubule, and the whole thing is just a seminiferous tubule. So this whole thing, seminiferous tubule. Who's lining the seminiferous tubule is going to be the Sertoli cells. And I'll look into this thing in detail. I'll tell you more about it. But first, let's read this from the book. So they line the seminiferous tubules. Spermatogonia was also the one they would line the seminiferous tubules, right? Spermatogonia are the germ cells, while Sertoli cells, they're non-germ cells. They're not germ cells. They're the Sertoli cells. Because why? Because they are just for their, they support and nourish those germ cells, which are spermatozoas. Okay. What do? They convert the testosterone and androstenedione to estrogen via aromatase. Okay. That's also important. They would convert, so just remember, they would convert that testosterone into estrogen via aromatase enzyme. Now, Sertoli cells are temperature sensitive. We talked about it, but mnemonic here is going to be S and temperature sensitive S. Line seminiferous tubules for S. They support sperm synthesis, all these S's, and inhibit FSH. Again, FSH. The last point, actually not the last one, but the homologue of the Sertoli cell is the granulosa cell in the females. Increased temperature seen in the varicocele and cryptorchidism. Okay. Now let's do some mnemonics on this thing so that we can memorize this. So Sertoli cells, the mnemonic here is going to be the fish. You can just think about fish, okay? What is fish? So Sertoli cell is going to release, let's do the normal thing first. Sertoli cell is going to release inhibin B, and that is going to inhibit FSH. Now, normally the FSH is the one which is stimulating the Sertoli cell to secrete inhibin B. Let's take a look at this picture so it might be understand better. Hypothalamus, we have the release of GnRH. GnRH works on the anterior pituitary, releases LH, and FSH, right? Both two things. FSH is going to stimulate Sertoli cells, right? And that Sertoli cells right here, right? That Sertoli cell is going to release inhibin B, which is going to inhibit the release of FSH from the anterior pituitary. Simple. So just know, I mean, if you think about it, it is all it's doing is it's trying to inhibit its own secretion by inhibiting FSH. Inhibin B is the main thing here, right? So you can think about it as two sorts of mnemonic. One thing is going to be the fish. With the fish, just remember, so let's just do it here, FISH. With the fish, you will think about FSH, right? FSH with inhibin B working on it. I for inhibin B. Inhibin B. This is one way to think of, or the other way could be just remember Sertoli cells, FSH for the S, as it has all the S, but I don't know how you're going to remember inhibin B with it. So that's why the this fish mnemonic would work better, I guess. That you can think of FSH, right? It is inhibited by, or there's a close relation of FSH with the inhibin B. And you can just think of what is the close relation that the inhibin B is going to inhibit. It is going to be secreted by Sertoli cells, and it's going to inhibit FSH. Okay, and that is seen here. That FSH is released from anterior pituitary, goes and works on Sertoli cells, stimulates the Sertoli cells. Sertoli cells, when get stimulated, they release inhibin B. That inhibin B inhibits FSH, although this looks very normal and simple here, but it's very high yield. It's like very high yield. Okay, can't even put more emphasis on it. But let's talk about now the Leydig cells. Okay, Leydig cells, here what we have is it secretes testosterone in the presence of LH. And this is pretty simple. Leydig cell, LH, okay. Testosterone is produced. Testosterone production is unaffected by the temperature. It has nothing to do with temperature, okay. Now, this is also very high yield. The testosterone is not affected by temperature. So these cells are within the interstitium, okay. They are the endocrine cells. They are the homologue of female theca interna cells. Let's take a look at this now. Hypothalamus, again, GnRH, goes on the anterior pituitary, releases LH and FSH. LH goes and works on, or stimulates, I should say, stimulates Leydig cell. Again, L for LH, L for Leydig cell. Leydig cell is going to release testosterone. That testosterone is going to go into the bloodstream, in the capillaries. Okay. And also is going to go into the lumen of the seminiferous tubules, as seen by this arrow. Now, with that, let's take a look at. So how can we memorize this part? Now, to memorize this part, well, the only thing I guess we need to know is LH, a Leydig cell, LH, and testosterone. So you can maybe have a mnemonic Leydig or testosterone. I mean, make some mnemonic, anything, you know. But testosterone, you gotta know two things: LH, Leydig cell, and testosterone. Sertoli cells, fish. With the fish, it's easy because Sertoli cell is going to release inhibin B, which is going to inhibit FSH. With the Leydig cell is going to release testosterone, which is going to inhibit LH. And taking a look here, let's take a look here at this picture. Testosterone not only inhibits LH, but also inhibits hypothalamus. So it sort of have a two-way negative feedback. That is also very high yield. Now let's take a look at this picture, a very high yield picture. So we have seminiferous tubules, and we have Sertoli cells, nucleus. So this whole thing is going to be the Sertoli cell. Okay, and the nucleus is just in the mid. So this whole thing is the Sertoli cell. Let's just draw it. Sertoli cell. Now this Sertoli cell is within the seminiferous tubules, but something is outside the Sertoli cell, which is known as the interstitium. That's the Leydig cell. It is not in the seminiferous tubules. It's outside, so it's called the interstitium here, and this is the Leydig cell. Right? That's one thing. Second thing, let's talk about. Let's change color here. Now, if you look here, the Sertoli cell, that FSH, let's take a look here. That FSH, if you let's zoom in here, the FSH is stimulating this Sertoli cell, which is essentially stimulating the Sertoli cell to have an androgen binding proteins release, so stimulate the release of androgen binding proteins, right? That's very high yield. And also, it sort of have two things. One thing is to release androgen binding proteins, and second thing is to release inhibin B, which is going to inhibit FSH. So two things for the Sertoli cells. Let's take a look at this image now. So first thing we have the spermatogonium or spermatogonias. They are going to produce from here all the way to spermatocytes. From spermatocytes, we have the spermatids, and the last thing we will have spermatozoon, right? And this whole thing is called spermatogenesis. Now, high yield point for spermatogenesis is going to be that they require high levels. Spermatogenesis require high level of local testosterone. High yield. They require high level of local testosterone. And where does the testosterone come from? Well, testosterone was coming from when you stimulate the Leydig cell, right? And that testosterone, it's going two ways. One thing is going into the capillaries, and second thing is going straight into the lumen of the seminiferous tubules, which gives off the local testosterone. But important than that is going to be something has to keep that within the lumen, right? And that's the androgen binding proteins. Where are the androgen binding proteins coming from? Well, these are coming from Sertoli cell, which is stimulated by FSH. FSH stimulates Sertoli cell, releases androgen binding proteins, which are going to bind those local testosterone and keep them there. Doesn't let them go into the capillaries, into the blood. Keep them there, and that local high testosterone level is going to cause stimulation of that spermatogenesis. So again, high level of local testosterone. FSH gives androgen binding proteins, which keeps, again, FSH gives stimulation to this, stimulates the Sertoli cell, which leads to release of androgen binding proteins. And this is going to bind those testosterone, which essentially gives high levels of local testosterone. And that is needed for spermatogenesis, one high yield point. Now, second point is going to be that if we have, for example, if we have defective FSH is defective, or we can say if we have the FSH receptor defective, that no matter how much FSH we have, it's not going to work on its receptor. Guess what? When it's not working on a receptor, Sertoli cells are not stimulated. When they're not stimulated, they're not going to have ABG, which is known as androgen binding proteins, right? When you don't have ABGs or androgen binding proteins, you don't have local testosterone levels. When you don't have local high level of local testosterone, you cannot have spermatogenesis. Spermatogenesis is not there. So with the FSH receptor defective, you can have no spermatogenesis, causing infertility. Okay, and when you check on the blood, there's going to be lots and lots of FSH. That is the reason when you check the blood and you see with lots and lots of FSH, with infertility, you can think of there's a receptor problem. There's a receptor problem. And when you have a lot of FSH, guess what's going to happen to your inhibin B? Where was inhibin B coming from? Well, inhibin B was coming from when the FSH was working on its receptor on Sertoli cell. Let's just say this is Sertoli cell. Sertoli cell, right? Sertoli cell. FSH receptor working here. That Sertoli cell is going to do two things. Cause, again, increase in inhibin B and also increase ABP, which is androgen binding proteins. Inhibin B is only there when this guy, which is the FSH receptors on Sertoli cell is stimulated, which causes Sertoli cell to release two things. But the problem is, now when we don't even have this, when we don't even have a FSH receptor, normal FSH receptor, when we do not have a normal FSH receptor, then that means no matter how much FSH you have, it is not going to work on its receptor. It is not going to release inhibin B. So, and it is not going to release ABPs. We talked about ABP causing infertility now, but with the inhibin B, when we don't have this in the bloodstream, we will see increased level of FSH and low inhibin B. Okay. Now with that, let's talk about something extra here, and that's going to be with testosterone. So here, so testosterone, as I told you here, that they would enter this lumen of seminiferous tubules, but let's mention more on this. So testosterone would enter Sertoli cells via the paracrine mechanism. Important thing. This testosterone, this is Sertoli cell. Okay, they are going to enter the Sertoli cells via paracrine mechanism to reinforce spermatogenic effects of FSH on Sertoli cells. Sertoli cells, when it goes, this testosterone, when it goes into the Sertoli cell, that Sertoli cell is going to convert that testosterone into estrogen by the enzyme known as aromatase, which we talked about up top. So again, high yield point that here. So testosterone converts the Sertoli cell converts that testosterone and androstenedione to estrogen via aromatase. But the question arises how that testosterone gets into Sertoli cells. That's through paracrine mechanism. Paracrine mechanism. That's a high yield point. Okay. Now let's talk about last thing here, and that is the FSH and LH levels over the lifespan. So over the lifespan, FSH and LH. So in childhood, what's going to happen to the FSH is you have more FSH than LH, but at puberty or in the reproductive age, the whole thing is going to shift. You will have more LH. Again, why we're thinking about LH being more in puberty and reproductive age, because the LH is the one which is going to secrete that specific hormones, testosterone, right? That is why in puberty and in reproductive age, you have more testosterone, because that LH is more in human body than the FSH. Okay. And then lastly, after the reproductive age, the whole thing goes back to as a childhood. For example, you have more FSH than LH. Okay. This is the life levels over the lifespan. With that, we are done with this page. Let's review it quickly and move on to the next part. Okay, so now let's just quickly review it. So we have spermatogonia simple. This is the germ cell pool which produce for primary spermatocytes. They are the germ cells. Well, they need some nutrition, right? They need some support and nutrition, which is given by Sertoli cells. Sertoli cells support and nourish these spermatozoas, okay, and regulate spermatogenesis, right? Sertoli cells. Now let's talk about Sertoli cells here. Sertoli cells, they secrete inhibin B, which inhibits FSH. The mnemonic could be fish, okay? They secrete androgen binding proteins. So two functions: secreting inhibin B, secreting ABPs, which are androgen binding proteins, maintain the local level of testosterone, which is needed for spermatogenesis. Produce MIF because these Sertoli cells produce MIF, which is Mullerian inhibitory factor, which is going to inhibit the Mullerian tube, right? And that Mullerian tube was needed for the female reproductive system, right? So when you inhibit that, or I should say Mullerian duct, not tube, duct, right? So it produces MIF, which inhibits Mullerian duct, because the Mullerian inhibitory factor, which is going to inhibit Mullerian duct, it has a tight junction because it does not want the blood to go into the gametes, and doesn't want any autoimmune attack on the gametes. So it has a blood testis barrier. It's high yield is temperature sensitive. Sensitive as for Sertoli cells, because with increased temperature you have decreased sperm production. The testosterone which gets into it through the paracrine mechanism gets converted into estrogen via aromatase enzyme, Sertoli, the mnemonics is all the SS. Sertoli cells, temperature sensitive. They support sperm synthesis, and they inhibit FSH by releasing inhibin B. It is similar to female granulosa cells, and they are increase in temperature seen in varicocele and cryptorchidism. Again, testes being within the abdominal cavity, causing increase in temperature. Then you have the Leydig cell. This is you can also think about lady cells. With the lady, you can think of when you see a lady, testosterone goes up. That's one of the mnemonics. Lady cells, testosterone goes up, right? So that's the testosterone. Lady is for LH. Again, Leydig cell, LH, and testosterone. Three things. Secrete testosterone in the presence of LH. Testosterone production is unaffected by temperature. Just one thing which is affected by temperature can be Sertoli cells. It is Leydig cells are present in the interstitium. Right here is the interstitium. And they are the endocrine cells, and they are homolog to the female theca interna cells. Now, looking at this picture here is simple, that you can see you have the seminiferous tubule. Within the seminiferous tubule, we have Sertoli cells. Sertoli cells do things. They are going to release inhibin B and cause release of androgen-binding proteins within the lumen of seminiferous tubule, and that ABPs, which are androgen-binding proteins, which will keep that testosterone locally, and that is needed for spermatogenesis. Now, compare that with LH. They are outside. They are outside, which causes they are present in the interstitium. They don't even have to deal with seminiferous tubule. But the important thing is they are the one which are going to secrete testosterone, right? So Leydig cell stimulated by LH releases testosterone, which goes into two things. It goes straight into this lumen, crosses through the Sertoli cell by the paracrine pathway, and then goes into the lumen of the seminiferous tubules and keep the level there for the spermatogenesis, and also goes into the capillaries. Okay, with that, we are done with this page. I'm going to start the timer for 7 minutes. Okay, and then we'll move on to the next one. And in those 7 minutes, kindly go for it, read it, memorize it. Take this time to go over the same material. Okay, welcome back. Let's talk about spermatogenesis. Spermatogenesis begins at puberty with spermatogonia. Full development takes about 2 months. Occurs in the seminiferous tubules, high yield point. This development takes about 2 months within the seminiferous tubules. It produces spermatids that undergo spermatogenesis, which is the loss of cytoplasmic contents, gain of acrosomal cap to form mature spermatozoa. The mnemonic here is going to be the gonium is going to be the sperm, and zoon is zooming to be to form an egg. So with that, let's take a look at spermatogonium. We said the gonium is going to be a sperm. When you see something as gonium, it's going to be something that is going to form a proper sperm. But when you see a zoon, which is right here, a mature spermatozoon, and this is the one which is zooming at the egg. Okay, so let's take a look at spermatogonium. Spermatogonium is a diploid. Is a diploid with a 46 chromosome 46 single chromosomes. Here the sex is going to be X and Y. With the tight junctions, if you recall, we said we have a tight junctions, and that is why we have this blood, which forms this blood testes barrier, so we don't have any autoimmune attack to the spermatogonium. Okay. And that is going into the replication, which is the interface, and it forms the primary spermatocytes. Now, the primary spermatocytes is again diploid with 92 sister chromatids, sex X and XYs. Undergoes meiosis 1, where the chromosomes numbers will get half. So 92 will get half into 46 and 46, right? And that's going to cause either the XX or the XY, XX and the XYY, right? And this is known as now the secondary spermatocyte, which is known as haploid. Okay, and then it is going to go into meiosis 2, which is going to convert that into single sex, which is X or the other X or the Y's Y. So if you think about it, Y with 23 chromosomes on each single one of them, and that's just called the haploid spermatid. With that, the whole thing goes into spermatogenesis, and then spermatogenesis is converting that spermatid into mature spermatozoon, which is zooming towards the egg. Now that spermatogenesis, the process of spermatogenesis contains that there is going to be a loss of cytoplasmic contents, high yield, and the gain of acrosomal cap. And this whole thing is called spermatogenesis, which is going to form the mature spermatozoa or spermatozoon. Okay. Now looking at acrosome, this is the acrosome, and here's the head with the nucleus, with the neck, and this is the middle piece and the tail. Now there are a couple of diseases which are high yield to talk about here. So if we have a tail immobility or tail mobility impaired, that is seen in ciliary dyskinesia, or also known as Cartagner syndrome, which causes infertility. So if you have a tail problem, which is tail motility problem, that's going to be seen in the ciliary dyskinesia, or Cartagner syndrome, same thing, which is going to cause infertility. Now, if there is a problem within the vas deferens, or there's an absence vas deferens, that is going to be seen in cystic fibrosis. Tail mobility is total normal in CF. Cystic fibrosis, they will have infertility, but the problem is going to be there is an absent vas deferens, high yield. Okay. With that, we are pretty much clear here, but let's just quickly review important things. Important thing here is going to be that you have it takes about 2 months for the full development. Okay, and it occurs in the spermatogenesis, takes about 2 months, occurs in the seminiferous tubules. We have spermatogenesis process. That process contains two things. One is loss of cytoplasmic contents and the gain of acrosomal cap, and that forms the mature spermatozoa or zooon. Those zooons are zooming towards the egg, and they will fertilize the egg. Gonium, the first one, is the one which is gonium is going to be sperm. Okay, well, zooon is zooming towards egg, so it's a mature spermatozoa. Okay, with that, high yield point is going to be about the tail, which is abnormal motility within the cystic fibrosis. My bad, not cystic fibrosis, but ciliary dyskinesia and Cottagner. But when you have a normal tail, still you have abnormality or infertility. That's going to be absence vas deferens within the cystic fibrosis patient, going to cause infertility. High yield points, high yield. Okay, with that, let's move on to the next page. Now this is relative high yield points here. So now within this page we have estrogen and progesterone. I want you to think about female hormones here. Okay, female. We talked about male, Sertoli Leydig cell. Now we're going to think about female here, and I mean, they should have mentioned here, but they did not. So that's why I'm putting up top female. So let's talk about each one of them. So first thing we have is the estrogen. The source is it is seen. It is in the ovaries, known as estradiol. Is in the placenta is known as estriol. Adipose tissue is the esterone via aromatization. So different names, all right, but the same thing, estrogen. Okay. Now potency is important. Now that potency for estradiol is higher than esterone versus estriol. So estradiol or estradiol is seen in where? Ovaries. So we can say ovary is most potent. Then you have adipose tissues, and that is going to be higher than the placenta. Okay, estradiol is produced from two ovaries. So diol, that's the mnemonic, right? Where is the estradiol coming from? Diol. So two things are just the ovaries, right? Then we have the function, high yield. What is the function of estrogen? Well, the function is going to be development of internal, external genitalia, right? Breast, female fat distribution. So secondary sexual characteristics and the external genitalia. Okay. Internal and external genitalia. Then you have the growth of follicles, endometrial proliferation. Now, if I ask you which layer of endometrium are they proliferating? So there's going to be endometrial proliferation of stratum functionalis. Stratum function, as the name suggests, functionalis is going to function, is going to proliferate, get stuff off, then get back there. It's a function, functionalis. It's functioning, right? Functionalis. And increases myometrial excitability. Then there is an upregulation of estrogen, okay, LH and progesterone receptors. So it is upregulating itself and the LH and the progesterone, and feedback inhibition of FSH and LH, then LH surge. High yield is this LH surge. Okay, and also stimulates the prolactin secretion, high yield. Decrease prolactin action on the breast. That's also high yield. So two things, it's stimulating prolactin secretion, but also causing at the same time, causing decrease prolactin action on breast. Okay. Again, what was the action of prolactin on breast? That was the milk let down. So it is decreasing that action on breast. Okay, increases the transport proteins, high yield, SHBG, which are the sex hormone binding globulins. Increase in HDL, decrease in LDL levels, right? On top of it, it also has some other things. For example, it's going to increase plasma fibrinogen levels. It is going to increase factor 7 and antithrombin 3. Okay, so and what else we can think of? It is protective against osteoporosis. So it protects against osteoporosis. And this is the highest yield point here. Because in post-menopausal women, when you have decreased estrogen, they have increased risk of causing osteoporosis. And this estrogen is also protective in the cardiovascular problems because it is causing increase in HDL and decrease in LDL. That's why in post-menopausal women, post-menopause is one of the risk factors for causing cardiovascular disease in women because it does not cause this normal action, which is increase in HDL, and good cholesterol, and decrease in bad cholesterol. Okay, one important thing other than that is going to be how is it causing increase in HDL and LDL? By causing increase in HMG-CoA reductase. HMG-CoA reductase. Okay, what else we can think of? So let's take a look at here now the next point here, the pregnancy. So the function within the pregnancy is 50-fold increase in estradiol and estrone, 1,000-fold increase in estriol, indicator of fetal well-being. Okay, again, estriol was coming from placenta, right? So if there's an increase of estriol, you think of, because the placenta is good, that means there's a fetal well-being. Estrogen receptors are expressed in cytoplasm. They translocate to nucleus when bound by estrogen. So they are in cytoplasm. So let's say this is cytoplasm. Estrogen comes bind to them, and then they go into the nucleus. High yield point. With that, let's take a look at this image here. Very high yield image. We have, let's just remove all the extra points. We have a follicle, and that follicle, again, let's just draw some things on it so we know what we're talking about. We have theca cells, we have the granulosa cells. If you look at theca cells, normally, you know, we talked about theca interna, theca externa, right? So it must have two sources layer, theca interna and externa. So here we go. Let's talk about them. So theca, this guy is theca. Let's just actually do it another way. So we have theca interna because it is internal side, and this is outside. So this is theca externa. Theca interna. So theca cells has two layers, theca interna and theca externa. Okay. Now let's talk about first theca externa, which has a minimal role. So let's talk about it. It just gives the structural support to the follicle by the connective tissue capsule. What is it made of? It is made of smooth muscles and fibroblast cells. Smooth muscles and fibroblast cells. So all it's doing is the job is to have a structural support to the follicle, nothing else, right? Now the theca interna, on the other hand, has a full sort of activity. So we have theca, let's just write them down here, theca interna. And the last layer here is going to be the granulosa cell. Granulosa. And after granulosa, all we are going into this, we have this here, that's the egg or oocyte. Egg, or you can say oocyte, okay? And this all is, again, let me remove this so you can see, this is all granulosa cell. This whole thing is all about granulosa cells. Okay, so now let's talk about, first of all, theca interna and theca and the granulosa cells. So theca interna, it is stimulated by, so look at this one, very high yield. LH is going to stimulate the LH receptor on theca interna, theca interna cells. That is going to cause increase in cyclic AMP. That cyclic AMP is going to stimulate an enzyme known as desmolase, high yield desmolase. That desmolase is going to convert the cholesterol into androstenedione. Androstenedione is an androgen. It's not estrogen, it is an androgen. Okay. And that, so just think about it. We are talking about what we're talking about, we're talking about female follicle cell, and in the follicle cells, theca interna is making first what? Androgen. Yield. And that androgen has to convert into estrogen, right? Because we, in the females, we don't want androgens, we want the estrogens. More predominantly, we want estrogen. So let's take a look here now. So this guy, which is the androgen, which is androstenedione, that is going to migrate from theca interna into the granulosa cell. It's going to migrate, and it's going to, when it migrates, we need another enzyme to convert that androgen, this is androgen, into estrone or estradiol, right? And that enzyme is called aromatase. But we need something that would stimulate aromatase. Aromatase is like, I'm sitting here, but I need activation, man. I need someone to tell me to do the work. I will do the job, but you got to tell me. Who's the guy who's going to tell the aromatase to do the work? That's the FSH. FSH works on its receptor, which is the FSH receptor, stimulates it, causes increase in cyclic AMP, and that stimulates aromatase enzyme. That aromatase will convert that androgen into estrone, and which is interchangeable. Estrone can interchange easily to estradiol or go back to estrone. Again, we talked about estrone being present in the adipose tissue predominantly, but these are all interchangeable within each other. They're almost the same thing. It's the potency which is different. All right. So estrone can convert into estradiol, which is the most potent of them. Or when it goes out, it has to be an estradiol, which goes out into the blood, which is known as now estrogen. Okay. Now, estrogen, once out into the bloodstream, it matures. It's going to mature the egg. Mature that egg. What is the egg we were talking about? That maturation? Right here, the follicle here. It's going to mature this follicle. Because in the follicle, what do we have? We had the egg. Oocyte, right? It's going to mature that oocyte into formation of secondary oocyte. Okay, so that's the whole cycle. Let's talk about cycle one more time quickly and move on to the next. So we said we have the theca cells. Theca cell has two sort of cells inside. We have the theca. Why am I mentioning theca interna, externa? Because I don't want you to get confused. Remember, there are two cells, theca externa, interna. Externa is just the connective tissue outside, which gives us structural support to the follicle. Theca interna is the main cells, which contains LH receptors and contains enzyme known as desmolase. That LH stimulates the LH receptor, causes increase in cyclic AMP, stimulates the desmolase, which is going to convert a simple cholesterol into androgen. And that androgen is it's a predominantly male hormone, androgen, not estrogen. It's an androgen that has to be converted into estrogen, which is estradiol, and that is done through granulosa cells. That androgen is going to migrate into the granulosa cells, and over there we got an enzyme known as aromatase. So FSH stimulates FSH receptor, causes increase in cyclic AMP, which stimulates aromatase enzyme, which converts that androgen into estradiol. That estradiol releases androgen within the estrogen within the bloodstream, and that estrogen goes and matures that egg, that egg, which is the primary oocyte, into formation of mature egg, which is the secondary oocyte now. Okay, and that is pretty much what we have. So now with that, let's talk about progesterone. If estrogen is doing all that, what is progesterone doing, right? So progesterone, which is formed by corpus luteum, placenta, and adrenal cortex and testes. Now, a corpus luteum is in the first trimester. This progesterone is formed by corpus luteum. That's also very high yield. That in first trimester of the pregnancy, corpus luteum forms as progesterone. Now, by second and third trimester, it's going to be formed by placenta. Okay, high yield point. First trimester, corpus luteum. Again, if you think about corpus luteum, what do we have for the corpus luteum? We had the follicle when the egg goes out. We have the formation of the remaining part of the follicle when the egg goes out is the corpus luteum, right? And that corpus luteum makes progesterone. The whole first trimester in pregnancy, that corpus luteum is going to make that progesterone. After that, we have placenta, which is now fully developed, which takes over. And in the second and third trimester, placenta is the one which makes progesterone. Okay, with the and adrenal cortex, when the child is born, adrenal cortex and testes will make progesterone. Now, the function of progesterone is during the luteal phase, it prepares the uterus for implantation of the fertilized egg. High yield point that it's going to prepare for fertilization of that egg. It's going to prepare that uterus for the egg fertilization. Now, how does it do that? First of all, it causes stimulation of the endometrial glandular secretion and spiral development. So remember one thing, glandular secretions. Second, spiral development. Production of the thick cervical mucus inhibits sperm entry into the uterus. Okay, why is it inhibiting entry into the uterus? Because it's right now the time is for this guy for progesterone. He thinks it's already it's doing is to have it's making the uterus for implantation. So getting ready that uterus for implantation. So it's like, hey, I don't want any more sperms going into, let's say if there are more oocytes, doesn't want them to fertilize. So increases, thickens the cervical mucus. This is will be seen in the contraception. And what is the how the progesterone is used as contraceptive, because it thickens that cervical mucus. Okay. Other than that, you have the prevention of endometrial hyperplasia. Okay, it's causing a very high yield point that it does not cause endometrial hyperplasia versus estrogen, which causes endometrial hyperplasia. Okay, increase in body temperature, decrease in estrogen receptor expression, high yield. If you look at the estrogen was the one which was causing upregulation of no matter estrogen itself or progesterone. It's like, hey, I don't want to choose between us, so I'm just going to upregulate myself and you. Will you do the same? Progesterone is like, yeah, I'm going to do it. But no, it's very mean guy. So what is it doing is decreasing expression of estrogen. He's like, nah, I should be the topmost priority here. Decreasing estrogen expression. Decreases gonadotropin, LH, FSH secretion, right? All of that. And then you have in pregnancy or during pregnancy, it maintains the endometrial lining in the pregnancy. Decreases myometrial excitability, decreased contraction frequency and intensity. High yield point is again decreases prolactin action on breast. We did say the same thing up top, decreased prolactin action on breast. But high yield point is this progesterone is the one which is causing more of this action. Decreases prolactin action on breast. Why is that? Because when we lose this progesterone, when we remove the placenta, when the child is born, the placenta is out, we don't have any more progesterone. When we don't have progesterone, that prolactin will start working on the breast and leading to milk letdown. Okay, high yield point. So with that, let's take a look at it falls. So with the estrogen, with the progesterone, we have fall in the estrogen and progesterone after delivery. Again, the same thing. After delivery, we don't have any more placenta. We don't have any more estrogen and progesterone. Causes lactation, which I just talked about. Because at delivery, this inhibits prolactin, meaning right now it was at the time of pregnancy, it was inhibiting prolactin action on breast, right? And when you don't have progesterone, or let's just say, let's add estrogen with it. When you don't have progesterone and estrogen, now what's going to happen is you will cause prolactin to work on breast, and that causes milk letdown, lactation, right? Increased progesterone is indicative of ovulation, high yield, because if you look here, increased body temperature, sometimes it is seen as when you have an increase in body temperature, you can think of ovulation, okay, in the female. Progesterone is pro-gestation. Prolactin is pro-lactation. That's easy. Progesterone, pro-gestation, simple. Okay, so this is the function of progesterone. Let's talk about something else. Also, progesterone also decreases bile acid secretion, decreases bile acid secretions by gallbladder stasis. So it causes, in supersaturation causes gallstones. That's one of the factors for progesterone. Other than that, we have, let's talk a little bit about corpus luteum. Corpus luteum regresses by the end of cycle. Normally, the corpus luteum by the end of cycle, menstruation cycle, the corpus luteum regresses, right? And that would cause decrease in progesterone, because progesterone was coming from this corpus luteum, but end of cycle, it regresses, decreases progesterone, or progesterone withdrawal will happen. That causes vasoconstriction of the spiral arteries, vasoconstriction of those spiral arteries. That's one thing. Second thing is going to be apoptosis of endometrial epithelium, and also sloughing of that functionalis, stratum functionalis. When you have apoptosis, causes sloughing of that functionalis layer within the menstrual flow, as menstrual flow, and also causes decrease in bile acids and gallbladder stasis. Okay, so let's review this page quickly. High yield page, okay, very high yield. So we're talking about here all the female estrogen and progesterone. Estrogen, three sort of estrogens we have to think of: estradiol, which comes from ovaries; estrol, which comes from placenta; and esterone, which comes from adipose tissues via aromatization. Potency is ovaries most potent, then estrone, then estrol. Okay. Now the function is it develops genitalia, right? The breast, the female, fat distribution, and secondary sexual characteristics of female. The function is to grow the follicle, which is right here, which you talked about extensively. Also causes endometrial proliferation. Again, what is endometrial proliferation? That's the hyperplasia. So if there is an hyperplasia just off endometrium, right, there's propensity to cause carcinoma. So only estrogen, if there's only estrogen, then it can cause endometrial proliferation, which is essentially can cause endometrial carcinomas, which we will talk about. Increase in excitability of the endometrium. Myometrium, not endometrium, but myometrium. The whole myometrium get excitable by estrogen. But what is high yield? That's going to be a couple here features that upregulates everything. You name it, it upregulates. Estrogen itself, progesterone, LH, feedback inhibition of FSH and LH, then LH surge, high yield, LH surge, stimulation of the prolactin, secretion, decreased prolactin action on breast, increase in transport proteins, sex hormone binding proteins, HDL, LDL, by increasing HMG-CoA reductase. Also, it protects against osteoporosis. Also, it increases plasma fibrinogen factors 7, 10, and antithrombin 3. All of them. So with that, let's take a look at here. Important things are you have to know that, okay, LH is going to stimulate desmolase enzyme on the theca cells. FSH is going to stimulate the aromatase enzymes on the granulosa cells. Okay, And that, when you have estrogen outside in the blood, it's going to cause oocyte to mature, that it will be known as secondary oocyte. The progesterone comes from corpus luteum. Normally, within the menstrual cycle, you have corpus luteum formation. That corpus luteum releases progesterone, which causes stimulation of the endometrial gland, spiral artery development, thickens the cervical mucus, increases body temperature. That all, right? But when you have regression of the corpus luteum, it causes decrease in progesterone. That decrease in progesterone, or actually I should say progesterone withdrawal, no progesterone be there, that's going to cause vasoconstriction of those spiral arteries. That will cause apoptosis of the endometrium, and that's going to cause sloughing of that striatum functionalis of the endometrium, right? In pregnancy, now is a total different thing. In pregnancy, what's going to happen, there is going to be maintenance of progesterone in the first trimester by corpus luteum. In second and third trimester, it's going to be by the placenta, which is going to maintain that corpus luteum, which is going to maintain that progesterone levels. That progesterone within the pregnancy will maintain the endometrium lining in pregnancy, decreases the endometrial excitability. So who was increasing the myometrium excitability? That was estrogen. That was the main thing. So versus estrogen, which was causing increase. So what it causes, it also decreases estrogen receptor expression. So it does not cause any myometrium excitability. Okay. Decreases contraction of the myometrium, and intensity and the frequency. Also decreases prolactin action on breast. Also on top of it, it's going to cause gallbladder stasis, and it's going to cause decrease in bile acid secretions. The easy way, a mnemonic: progesterone is progestation and prolactin is prolactation. Okay, when we have fall of estrogen and progesterone after delivery, meaning after the delivery of the fetus, that's going to deliver the placenta. When the placenta is out, we're not going to have any more progesterone, any more estrogen, high levels I'm talking about here. And that's going to disinhibit that prolactin. When you disinhibit prolactin, going to cause lactation, which is milk letdown, which is the prolactation for prolactin. And that is all for this page. Let's take a break and get back after break. What do we have? I mean, we're going to continue about for about 11:45, I would say. So let me start the break time. Okay, now let's talk about oogenesis. Oogenesis is the primary oocyte begin meiosis 1 during fetal life and completes meiosis 1 just prior to ovulation, high yield. So meiosis 1 is arrested in the prophase, PRO. O is for the 1, for years until ovulation, right? Which is the primary oocyte. The important thing is that these oocytes, they are formed by embryogenesis, or I should say during embryogenesis. So all the oocytes are formed during embryogenesis. When it's embryo, all the oocytes are formed. Okay, but now they remain arrested, but they remain arrested within arrested in meiosis 1, in the prophase 1, until ovulation. So if you look here in this picture, so all the primary all these oocytes, they are formed, they're already there, they're formed during embryogenesis, but they are going to be arrested within the prophase 1 until ovulation. They're arrested within prophase 1 until ovulation. At the time of ovulation, now what's going to happen is, now that is going to release that egg, and that is going to then, that egg is going to get arrested into the in meiosis 2, in metaphase 2, for fertilization. Now, so here, so this egg is arrested now in meiosis 1. Now after there's an ovulation, now these secondary oocytes, they are ovulated, they're already outside, but they are going to wait for fertilization. They will be arrested in metaphase 2, in meiosis 2, for fertilization to take place. Now, once, if they get fertilized, then they're called the ovum. Okay. Or the ovum will get fertilized. So let's read this. If fertilization does not occur now, and how long do they have to get fertilized? 1 day. The life of an egg is only 1 day. It has to get fertilized within that day. Otherwise, that secondary oocyte, this is going to degenerate. Okay. So let's just review this part and move on. So we have the oogonium, which are the diploids, 46 single chromosomes. They will go into interphase replication, 46, 90, will form primary oocyte, which has 92 chromosomes. And that is going to get arrested until ovulation occurs. So all this puberty till, like, let's say 13 years, they're going to be arrested. And at the time of ovulation, they are going to fulfill the next cycle. So they're going to be arrested. High yield is they will be arrested with which phase? That's the prophase. PRO. O is for ovulation. Okay, they're going to be arrested in the prophase for years until ovulation occurs. And the time of ovulation, that primary oocyte will form into secondary oocyte, and that secondary oocyte is 46 sister chromatids and a polar body, which can degenerate or give rise to 2 polar bodies. So this can degenerate as soon as it goes out in ovulation, or it can again give rise to 2 more polar bodies. And that that secondary oocyte can get fertilized and known as ovum. Okay. So now the important thing here, what you have to know is meiosis 1 is where, first of all, before even that, oogenesis, all are formed. Oocytes are all formed within the embryogenesis. but they're arrested. Now, important thing is they remain arrested in the meiosis 1 in the prophase 1. Okay, so prophase for ovulation, primary oocyte. Now, even if they get ovulated, now they will be arrested in the meiosis 2, in the metaphase 2, until fertilization. They have 1 day to get fertilized. Otherwise, they will just degenerate. Okay. So let's talk about ovulation now. Ovulation is when you have a follicular rupture and a secondary oocyte. This guy, secondary oocyte formation or release, right? Secondary oocyte gets released. So you have, let's say this is a follicle. That follicle, there's a rupture of the follicle and the release of the secondary oocyte. And the question is, why did this happen? Well, it happened because you had a LH, sudden LH surge or release of LH. It's called LH surge at a mid-cycle, high yield, and that causes this egg to go out, which is the secondary oocyte to release. Okay, so estrogen normally inhibits LH release. High yield point, as we talked about it, estrogen inhibits LH release. But high estrogen at a mid-cycle transiently stimulates the LH release, causes LH surge and ovulation. We will talk about that all in the menstrual cycle. But here, just know that there's an LH surge which causes ovulation, okay? And we talked about, another thing we will talk about is this. Normally, you have the estrogen, which is going to inhibit LH release, simple. Right? But at a mid-cycle, the estrogen is going to transiently cause stimulation of LH release, and that stimulation leads to LH surge, and that surge would cause ovulation. Okay. Now there's something known as middle schmerz. Middle schmerz is, just remember, as a middle Hertz. It's a pain with ovulation. So as the egg is getting released, just at the ovulation, there might be a middle schmerz with a middle pain because of that rupture, and that pain is known as middle schmerz, which is the middle Hertz. That's just a mnemonic, middle Hertz, meaning middle pain during or at the time of ovulation. It is associated with peritoneal irritation from normal bleeding upon follicular rupture. So again, same thing which I just talked about, that you have a follicular rupture and that causes release of pain. And remember, you have the fallopian tube, right? And you have the ovary. And the ovary and fallopian tubes, they are not attached, right? So when you have the follicular rupture right here, for the oocyte to go into, remember, they're caged by fallopian tube. Fallopian tubes, they are not attached to the ovaries. The egg is catched by the fallopian tube. But when you're catching it, when you're rupturing this, first of all, the follicle here, there's going to be bleeding, a little bit bleed, right? That bleed is going to go into the peritoneum. That peritoneum will get irritated and you will have pain because of normal bleeding upon follicular rupture. Typically, it's going to be unilateral and mild, okay, only one side, because only one side is rupturing at one point, but could be bilateral when there is a bilateral rupture of the follicle, and can mimic acute appendicitis. Again, if you recall, what is acute appendicitis? Right lower quadrant pain, right? But again, that's going to be, but this pain is there. So you can think of, it mimics, so differential diagnosis, right lower quadrant pain, you think about appendicitis, right? So that is why in middle schmerz, which is the middle pain, that is also on the right lower side, or it could be left lower side, depending on which side is ovulating, right? And that could tell us maybe there's a pain of appendicitis. So differential diagnosis there. With that, let's talk about what's going to happen. There are going to be three things at the time of ovulation. You will have increase in body temperature, increase in basal, body temperature, right? One thing. Second thing is going to be that you have increase. First of all, LH surge is the one which is causing ovulation. Remember that part. Now, once you have ovulated, at the time of ovulation, or when you have already ovulated, you have increase in basal body temperature. You have increase in serum progesterone levels. Why is that progesterone? Because remember, corpus luteum will start producing progesterone. What is corpus luteum? We have the follicle. That follicle, when the egg goes out, the remains become corpus luteum, and that secretes progesterone. That's why you have increase in progesterone, and that LH will go out in urine, so you will have increase in LH in urine levels. Okay, and that is pretty much what we have for ovulation sign symptoms. Okay, and that's it. What's next here? Menstrual cycle. Okay, we can actually finish this page as well. High yield page. Zoom in. Okay, let's start this one. Now let's talk about menstrual cycle. Now, menstrual cycle, it's a regular cyclic change periodically preparing the female reproductive system for fertilization and pregnancy. Occurs in phases based on events taking place in ovaries and uterus. So we have the ovarian cycle within the menstrual cycle, and we have the uterine cycle for the uterus, what uterus is doing in the menstrual cycle. So ovarian cycle is when we have, first of all, let's just take a look here. First day of menses to ovulation, and from ovulation to the first day of the next menses. Okay, so when we have the first day of that menses to ovulation, what we have in the ovarian cycle is the follicular rupture or follicular phase, which is the follicular development. Late stages are stimulated by FSH, can fluctuate in length. And we will talk about this all here in the, let's actually take a look here, way better if you just look here. The follicular phase in the ovary, what do we see? We have, first of all, look at this. We have the primordial follicles. Those primordial follicles, when the follicular phase, they are going to form developing follicle. That developing follicle will form Graafian follicle, which is the mature follicle. And then we have ovulation. And that after ovulation, the remains of the follicle is formed, known as corpus luteum. And that corpus luteum will go on and regress. And that regression of the whole corpus luteum is known as corpus albicans. High yield points, again, the names are high yield. What do we have? You have the developing follicles, mature, Graafian follicle, corpus luteum, and corpus albicans. But let's talk about a little details here. That what do we have? So let's not read that first. So let's just try to see what we can see here, and then we will read the top. So we are talking about ovarian cycle here. Ovarian cycle, we first of all think about hypothalamus. Hypothalamus is secreting GnRH. Can you recall, is this GnRH a continuous GnRH secretion or a pulsatile GnRH secretion? If you're saying pulsatile, you're right. So the hypothalamus releases in pulsatile fashion that GnRH. And it secretes that in the portal circulation, and that goes into the anterior pituitary. And GnRH stimulates that anterior pituitary, right? Which again releases, is it releasing in continuous fashion or intermittent fashion? Well, again, intermittently, it's going to release FSH and LH. Okay. Now we have, finally, we see FSH and LH here. Now we have two phases. We have the follicular phase and we have the luteal phase. The follicular phase, again, as the name suggests, is going to develop that follicle, right? Follicular, follicle, right? All we have in the follicular phase is that development of all this follicle. So let's talk about that. Now, FSH is going to cause developing of, if you look here, FSH is causing developing of the follicle, right? And that developing of the follicle, and we talked about how the development of follicle occurred. For example, developing a follicle from developing follicle to mature follicle and moving on that way, right? But let's talk about FSH more. So FSH is causing the developing of the ovarian follicle, and also FSH is going to stimulate estrogen production from ovaries. Okay, and let's talk about that a little bit because we didn't touch that. So FSH, now remember, high yield points, what I'm mentioning all here. FSH is going to stimulate developing follicle. That developing follicle is going to granulosa cells to produce. Remember, we in the developing follicles, we had something granulosa cells, right? That granulosa cell within the follicle is going to produce estrogen. Can you recall who was stimulating the granulosa cells to make estrogen? That was FSH. Exactly. Again, very high yield points. You got to connect all these dots, right, to understand the whole scenario here. High yield. FSH, it's doing two things here. First of all, it is developing the follicle, okay, from the primary, this is the primary follicle, into developing follicle, then mature and everything, all the follicles, right? It is by FSH. Just remember, FSH is stimulating developing follicle. That developing follicle it has a granulosa cells which are going to produce estrogen, right? So when I say the FSH is stimulating estrogen production from this ovarian, from the ovaries, or I should say from the granulosa cells, that makes sense, right? So FSH is doing two things: stimulating developing follicle and also stimulating the estrogen production. Now, when you have production of estrogen, which is right here, that estrogen in turn is going to do a lot of other things. What is estrogen doing? Let's mention them here. Well, estrogen is going to progressive increase in estrogen is causes that LH surge by the end of follicular phase. So let's take a look what I mean by all that. So if you take a look at estrogen, there's a progressive increase in estrogen. It does not just increase right away. There's a progressive increase in estrogen, right? Because all of that graphene follicle, all those granulosa cells are producing estrogen. You have more and more estrogen. But there's going to be a point just before you start the luteal phase. There's going to be so much high level of estrogens. And that high level of estrogen just before the luteal phase starts is going to cause LH surge. Okay, and I'll talk about how. So just remember, this estrogen is causing a progressive increase in estrogen, which causes LH surge, which is right here, LH surge. Okay, how is it causing that? By a positive feedback effect on the LH production. if you recall, we talked about it in the mid-cycle here. Everything is interconnected. Okay, you got to know the whole thing here. Ovulation, simple thing, yet important. LH is released in the mid-cycle by the LH surge. The ovulation occurs in the mid-cycle by the LH surge. Estrogen, we talked about it. Estrogen normally is inhibiting LH release. That's normal function of estrogen. But at a mid-cycle, this estrogen is going to stimulate the release of LH, which causes LH surge, right? We talked about it. And here in this diagram, we can now see what we talked about. This estrogen, it is increasing, right? Look at the LH levels. Nothing. No LH, because estrogen is inhibiting, is inhibited by estrogen. So estrogen is inhibiting LH. But at a mid-cycle, estrogen will stimulate that LH, which causes surge of LH. And that surge of LH will cause rupture of the dominant follicle, or you can say rupture of the mature follicle, leading to extrusion of that ovum. You can see this ovum coming out. It is known as ovulation. Okay. Now, so the whole thing was all about FSH. So now you ask, what is LH doing, right? LH was only there to cause ovulation. Nothing else. Nothing else, only ovulation. Okay. So now with that, let's take a look at, now we know the whole story. So let's take a look at the ovarian cycle now. Ovarian cycle, here we have the follicular phase and the luteal phase. In the follicular phase, which is this one, there's only formation of the follicle, which is stimulated by FSH, can fluctuate in length. Well, the luteal phase, which is the corpus luteum, that's the luteal phase, luteum, corpus luteum, right? Corpus luteum formation, and the follicular remnant, which is stimulated by LH, fixed 14 days. Okay, so luteal phase, which is after ovulation, is going to last 14 days. Fixed. Okay. So now let's take a look at what's going to happen when we have that estrogen, that high level of estrogen here. What is that causing on the uterus? So estrogen, as you can see, as it is increasing, right? It is causing, first of all, you had so it's causing what? Proliferation. As you have increase in estrogen, it causes proliferation of the endometrium in the uterus, right? So let's talk about that. So again, estrogen causes what? Increases in the uniform endometrial glands, uniformity of the endometrial glands, non-edematous stroma, increase in length and girth of the glands, no secretions, stimulates endometrial proliferation of stratum functionalis. Just remember, if you just remember estrogen is causing proliferation, you'll be good. And you can see how it's causing proliferation. Just remember stratum functionalis. Okay. Because if you think about these spiraling of arteries and secretory and edematous glands, this is all through the other one, which is the progesterone. So remember, the estrogen is the proliferation. Now, we had the estrogen, we said the higher the estrogen it's going to cause in the mid-cycle is going to cause stimulation of LH as a positive feedback, which causes LH surge, which causes ovulation. Now, looking at a progesterone is nowhere to be found in the follicular phase. Why? Because progesterone is found by the later on corpus luteum. Let's go back a little step again. Think about it one more time. We are talking about developing follicle. That developing follicle, again, think about it. It's a simple thing. Developing follicle has granulosa cells. Those granulosa cells are making estrogen. Once the ovum, or once the secondary oocyte is out in ovulation, all that remains is called corpus luteum. Corpus luteum does not have any Graafian follicle, doesn't have anything. All it has is all it produces is the progesterone. All it produces is progesterone. So before the ovulation, you had primary follicle formation into developing follicle, leading to formation of mature follicle. All these follicles which are active, right? They are going to produce estrogen. Once the cell is out, once the ovum is out, the remains of that follicle, which is known as corpus luteum now, is going to produce progesterone. Okay, and once you don't even have a corpus luteum by the end of menstrual cycle, you will not produce any more progesterone. Progesterone is going to be low now. So only one thing: corpus luteum produces progesterone. What is progesterone doing? Well, progesterone, which is this blue, not a blue, but purple line here, this purple line is going to form secretory phase of the uterus, and that is formation of spiral arteries, glands to coiling of the glands, formation of spiral arteries. Endometrial stroma becomes edematous and contains tortuous spiral arteries that extend from the deeper layer of the uterine lumen, all of that. So if you can recall just one word, that's going to be secretion, formation of spiral arteries, and increasing the glandular surface. That's all it's doing. All it wants to protect the fertilization. So make it spongy, make it warm, give a lot of blood there, so that if it were to fertilize, then you have a lot of support for it. Okay, that's the progesterone. Progestation. Remember the mnemonic: progestation. Okay. With that, let's talk about. So we did talk about estrogen doing all this, progesterone, and when we don't have any more progesterone, it's going to cause menses, which is the blood flow or uterine bleeding. So in the menses and proliferative phase, you can think of them as proliferation is all about proliferation. Remember, why is it? Why would you have proliferation? That is due to the fact that you have estrogen. Remember estrogen here. And why would you have secretory phase? Remember, it is due to the fact that you have progesterone. And this one, secretory phase, is going to be for 14 days here. 14 days. And when you lose that progesterone, why would you lose the progesterone? Because that corpus luteum is going to degenerate into corpus albicans. And when you lose this corpus luteum, you're not going to have progesterone. When you don't have progesterone, you are going to go into menses, which is uterine bleeding. Okay, uterine bleeding. So now let's read the uterine cycle. Here what we have is the proliferative phase and the secretory phase. As I mentioned below there, we have a proliferative phase and a secretory phase. Now, the proliferative phase, all you have is the endometrial development, which is stimulated by estrogen, straight, narrow endometrial glands. While the secretory phase is endometrial preparation for implantation, stimulated by progesterone, tortuous, dilated endometrial glands, spiral arteries, edematous glands. Everything has been expanded for implantation. Okay. So that's pretty much what we have here. Let's talk about some extra points here. So just before, so let me change color here. Just before ovulation, we have increase. So this is ovulation. Just before ovulation, we have increase in GnRH, increase in GnRH, increase in FSH, and there's going to be so much increase in LH, which causes ovulation because you had estrogen also stimulating the LH release. That's just before ovulation. So after ovulation, what we're going to have is we will have only increased level of progesterone. Again, high yield point, just before ovulation, you have everything increase in GnRH, increase in FSH, but way too much increase in LH and increase in estrogen. But after ovulation, the only thing that you will have an increase is going to be increase in progesterone. Okay. Follicular phase, remember the follicular phase. Follicular phase ends with ovulation, right? And it is not constant because you don't know when ovulation is going to take place. A luteal phase occurs after this. Luteal phase occurs, which is for 14 days, fixed 14 days, right? And that is going to end with menstruation. The last thing is the menstruation cycle, uterine bleeding. So we can, in other words, we can say, let me erase this part. In other words, we can say ovulation occurs 14 days prior to the day of menses. Prior to the menses, right? Regardless of the length of the cycle. So now let's also mention, while we're mentioning this part here, the menstrual cycle normally is about 21 to 35 days. So you can say 28 plus minus 7. And menstrual flow is about 4 to 6 days. Okay. With that, let's talk about a little more extra stuff here. And that's going to be just a summary of all this. So we have in the follicular phase, what's happening in follicular phase, we have the estrogen, which sends a negative feedback. This is a very high yield point, negative feedback to the anterior pituitary. Negative feedback to anterior pituitary and when you're sending negative feedback, so that means you are inhibiting LH release. This is follicular phase. Luteal phase, estrogen plus progesterone, both are sending negative feedback to the anterior pituitary to not release LH and FSH. But at the mid, let me change color here, mid-cycle, estrogen is going to stimulate, and that estrogen is very high levels of estrogen. One more thing is very high level of estrogens, high levels, is going to stimulate that anterior pituitary to release LH, and that LH is going to cause LH surge, and that is going to cause ovulation. Okay, other than that, let's talk about a little bit of when you have, let's say you have no ovulation, when you did not ovulate, there is no corpus luteum formation, leading to no progesterone, right? When you have no progesterone, that causes no proliferation, no secretory phase of the uterus. So uterus doesn't get spiraling, edematous, and all those glands. So there's going to be no bleeding, no uterine bleeding, right? So in other words, we can say lack of ovulation causes estrogen-driven lack. Let me put it this way: lack of ovulation leads to estrogen-driven proliferation is there. So estrogen-driven proliferative phase without without subsequent progesterone secretory phase. So basically saying estrogen causes proliferation, yes, but there is going to be no secretory phase of the endometrium, which would result in uterine bleeding. So all you're getting is proliferation. And so lack of ovulation will cause uterus to proliferate, and which can cause endometrial hyperplasia, and that is a risk factor for endometrial carcinoma. Okay. And that is pretty much what we have. So let's review the whole thing and move on. Okay, so here what we have is we have a menstrual cycle. We have to think about two sorts of features in it. We have the ovarian part and we have the uterine part. In the ovarian part is all about releasing that follicle. First of all, we got to mature. We have to make the follicle mature and then release the egg, and then make regress that remains of that follicle. So when we are and who's going to develop that follicle? That is done by FSH. FSH is going to form that follicle, and if you recall, follicle also had granulosa cell. So FSH is going to cause release of that estrogen. Okay, that's one thing. So within the follicular phase, FSH is causing developing a follicle, releasing of that estrogen. Estrogen is going to get higher and higher, right? But when it is at the highest, which is the mid-cycle, it is going to cause stimulation of LH. When you stimulate the LH, you have more and more LH, and that LH will cause LH surge. Surge basically means so much LH, that there are so much high levels of LH. And that so much high level of LH is going to cause ovulation. How is that occurring? Because that LH is going to rupture that developing follicle, and that releases the egg or the ovum. Okay, that follicle, now the egg is out in the fallopian tube, and the remains of the follicle is known as the corpus luteum. Now that remains of that follicle, which is known as corpus luteum, is going to produce progesterone. Progesterone and estrogen, right? Progesterone. So let's talk about what estrogen was doing on the uterus. So estrogen is just proliferating the endometrial layer, causing endometrial hyperplasia. Okay. Now progesterone comes in and it says, hey, no, we want to make it secretory phase, meaning we want to make a lot of blood arteries there, which are the spiraling of the arteries. One thing, we have to make more gland here, so it makes it more glandular and makes a lot of spiraling of the arteries, and that's done through the progesterone. Now that progesterone is going to cause secretory follicular, secretory endometrial secretory phase of the uterine cycle, right? Now, progesterone was coming from where? From the corpus luteum. So this 14 days period here, what's going to happen is this corpus luteum would degenerate. If it's not going into implantation, then it will degenerate. But if the ovum gets fertilized, then it remains there for about first trimester, and it keeps producing that progesterone, right? For first trimester. And then second and third trimester, placenta will take over and make progesterone. And all the job of progesterone is progestation, making the uterus more high level of nutrition there, high level of spiraling of arteries. So you have more glands, you have more blood supply to make progestation, to have gestation there, right? Implantation and gestation. But now, let's say here, corpus luteum was making progesterone. When we don't have any more corpus luteum, which goes and degenerates into corpus albicans, which does not produce progesterone, Now the patient is going to go into a menses, which is the uterine bleeding. But this is the whole cycle. And that is pretty much it for menstrual cycle. With that, we are done for the day. We'll talk about the next part tomorrow. All right. Have a good one, guys. Thank you for joining.